So, Mary, as New York City's health commissioner, you oversaw many initiatives to address the sources of health inequities. Which initiatives do you think would be most helpful in the context of addressing this COVID-19 epidemic?
Thanks, Vivian, and thanks for letting me be an honorary member of the class of '73, where I had many friends in that class. So, you've asked a simple question that doesn't have a simple answer. Public health really extends beyond the boundaries of technical interventions that address communicable disease control. Of course, communicable disease control is a core function of public health. And the first tool that public health always has is data. You've mentioned the data already, which very early in this pandemic, within the first month of the first death reported in the United States of COVID-19, we began seeing very large racial disparities in both infection rates and in mortality. And so being able to identify these disparities is a key role of public health. And then we have tools which are useful even when there is no specific treatment, which we don't yet have for this virus, and there is no vaccine. And those include testing, identifying people who are infected, either isolating the infected, finding the people who they've been exposed to, quarantining those, standard stuff. But of course, in the United States, we've really made a mess of it. And we continue to have an out of control pandemic in many settings, despite the success in some settings like Boston, where I am now, or New York City, where I used to live. So those are technical tools, but they run up against the ability of people to follow public health advice. And those are related to what you described as the social determinants of health. And this pandemic has really displayed the fissures in our society. There hasn't been a single year since the founding of this country. In fact, beginning even before this became a nation, when people of African descent haven't been sicker and died younger than whites. And we have seen that on real display. That's not because there's any inherent biological difference. It's because of the social dimensions of race and what it means about everyday life for people of color in this country. So the answers are to use your public health tools. That means investing in public health, which the United States is not doing. The investment in public health has declined in recent years, both nationally and locally, meaning that state health department budgets have gone down by close to 20%, as have local health department budgets in the past decade. And astoundingly, the United States, which already spent less than any other wealthy country on public health, has seen its share of the GDP expended on public health decline. So that was not a good plan. And then, of course, we have to focus these tools on the populations where the disease is having the biggest impact. And these tools work. We have the capacity to implement them, but unless we acknowledge the fact that people can't follow our advice, if you live in the Navajo Nation and have no running water, telling people to wash their hands frequently is not reasonable advice. Or if you have to work and you must continue to go to work in order to feed your family, and of course we have hunger on the rise in poor communities now, then telling people to stay home and work is not possible. It's all the things that you mentioned in your introductory remarks have fed into what we're seeing now. Somebody just put in the chat an analysis that I and colleagues did at the School of Public Health, which shows very large disparities in the risk of dying of COVID by race, by age group, and particularly among younger people. And these are data that have just been made available. The federal government has been shockingly irresponsible in not making data publicly available rapidly. But the data show, for example, The most stunning example is Blacks between the age of 35 and 44 are ninefold higher risk of death, have a ninefold higher risk of death than their white counterparts in that age group. Ninefold. So that's not due to comorbidities. The underlying, which are often referenced, the underlying diseases that we're talking about are very common among all Americans, and they carry an excess risk of no higher than twofold. But when you see a ninefold higher risk, something else is going on, and that's living in crowded housing, living in multi-generational housing, continuing to work outside the home and getting there on crowded transport,